Thank you so much, Paul, for inviting me to speak to you virtually today. I'm very honored to be part of this group, and I'm really excited to speak about robotics and incorporating it into both simple and complex MIS cases. Looks like you guys have had a great morning so far. And I know I'm not supposed to include disclosure slides, but I do want to talk about this a little bit. I am biased in the sense that I did my fellowship with Nick Theodore at Hopkins, and he was the inventor of the Globus Excelsius robot, which I'll be talking about today. And together we had the opportunity to do the first surgery with the robot back in October of 2017. That being said, we actually don't have an Excelsius at Stanford. We have a Mazor, and I'm a consultant neither for Medtronic or Globus. So first of all, let's get started with why should we even be using robots in the first place? Is it because they look really good on brochures and they're very attractive for hospitals and for surgeons? Maybe. I know obviously there's been excitement about that, but I think that what we can do with robotics, and we see it in our current generation and even more so in the future generations, is that we can capture patients who are seeking less invasive surgery. We can reduce radiation exposure for surgeons, surgical team, and patients. We can begin to really focus on procedural consistency, and I'll talk a bit about this. And then also, I think that integrating robotics into your workflow can be great for preoperative and intraoperative planning purposes. And I'll start first by saying that I think that navigation is a critical foundation for robotics. I don't always use robotics, but I pretty much always use navigation. This allows for high accuracy and high precision placement. I think I'm speaking mostly to young surgeons in the room there. And I know that some of the older surgeons and some of the folks who mentored and taught me might disagree with this. But bad things can happen, okay? And we always think about the challenge of placing, C1 and C2 screws or thoracic screws, but it actually turns out in the United States that most of the lawsuits are related to misplaced lumbar pedicle screws, which we often think of as being the easy ones to place. And an average lawsuit in the United States is over $1 million. And as I'm sure many of you know, neurosurgeons are one of the most commonly sued subspecialties in the US. And on average, the typical neurosurgeon gets sued once every 3 years. So when we look at the data, when we compare conventional screw accuracy to 2D fluoro accuracy across both cervical, thoracic, and lumbar screws, there is an incredible improvement in the accuracy of screw placement as we go from the conventional freehand technique to 2D fluoroscopy, and finally to 3D navigation. And I've got these pictures here of a compass, those old-fashioned maps that we used to use, and GPS. I mean, is there anyone here who would not use GPS to figure out their way in a new city and would pull out a compass or get one of those old-fashioned maps if they had that technology? I don't think so. And when we did our meta-analysis of over 50,000 screws, we found, not surprisingly, that CT navigation had the highest accuracy, and this is across all parts of the spine. And in particular, robotic-assisted screws actually had the highest accuracy in the thoracic spine. So just a little background on surgical robots. So the first robot to actually be used in neurosurgery goes back to 1985. So this was the Puma surgical robot, which was used to position a needle cannula for a brain biopsy. And then it was actually in the 1990s that one of Dr. Theodore's former colleagues, Curtis Dickman at the BNI, used the ASOP robot, which is used for thoracoscopic surgery. And he actually used that in spine surgery way back in the 90s. This was used when he was doing some thoracoscopic spine surgery. He used it to hold the endoscopic camera, and he was doing some hyperhidrosis surgeries, thoracic schwannomas, and thoracic discs. And then, of course, we're all familiar with probably the most popular surgical robot worldwide, which is the Da Vinci surgical system, invented in 1999. There are over 6,000 robots worldwide, and when I last checked, over 8.5 million surgeries have been done with the Da Vinci robot. In spine, the spinal robotics really started with Mazor, which was a company based out of Israel, I believe, back in the early 2000s. And you can see here the new generations, including the Mazor X, and most recently the Mazor X Stealth, which also incorporates Medtronic's Stealth navigation system. And these early versions allowed us to place K-wires so that we could then put in screws over the K-wires. And these have obviously evolved now using the latest technologies. And so some of the limitations of the first round of spinal robotics included issues with registration. Some of the different models that are on the market require mounting to either the patient or the table. The first versions only allowed us to place K-wires, so we weren't able to place screws through these. And many of the surgeons initially using some of these first systems found that these led to increased operative time. And as I mentioned initially, they weren't integrated with navigation technology systems. So the Excelsius GPS robot was FDA approved in 2017, and essentially it's what the FDA would call a cobot, okay? So this robot is assisting the surgeon, but the surgeon is actually doing the drilling and placing the screw and everything through the end effector, which is shown here. And just a quick question, can you guys see my moving arrow on the screen?
Yes, we can see it.
Okay, perfect, great. So you can see here the Excelsius GPS robot. You can see the screen here, which when in the video for the workflow, this is draped sterilely. And then you can see here that this is the end effector through which you can drill and tap and place screws. So some of the initial advantages of this system was that it was mounted to the floor. So you see that this is the robot that's brought in that I showed you the picture of, so not the patient or the table. It has a more rigid end effector than some of the earlier systems. So you can tap and place screws through it, not just K-wires. And I will add that the current version of Mazor X also allows for this, which is very important. It's integrated with navigation in real time, and you can do either pre-op or intraoperative CT scan registrations. And then another feature of it, which you'll see in the video, is that it uses two patient-mounted reference frames to avoid malregistration, because you can unintentionally dislodge it. And for all of us who are familiar with using navigation, we know how important it is when you have that reference frame on the patient. You don't want to move it, right? And similarly, that's also very important in using robotics. And so with the Excelsius GPS robot, there are two ways to help prevent that. And so this is actually a video that we put together with Nick Theodore. So you'll hear his voice. And I hope that this runs and it'll take us through the workflow of a case. Now, this is a video that we put together for an open case, but there are lots of similarities with MIS cases as well.
This is a case of a 75-year-old gentleman.
And just double checking, video works. Video and audio is working for you guys?
Yeah, it's loud and clear.
Perfect.
Who has previously undergone 3 lumbar surgeries with decompressions from L3 through L5. There is evidence of instability and loss of sagittal balance. He's an excellent candidate for a revision decompression from L3 through S1 with pedicle screw instrumentation and correction of his deformity. These surgeries can be challenging, especially given a patient's history of multiple prior surgeries. In this case, we will be placing robotically assisted pedicle screws with the usage of Excelsius GPS robot. Robotic workflow allows the surgeon to use 3 different imaging paradigms: preoperative CT with intraoperative registration utilizing fluoroscopy, intraoperative CT, or intraoperative fluoroscopy. In this case, the patient is positioned prone on the Jackson table to allow usage of the intraoperative CT scanner. After positioning, instruments are registered to the infrared camera, which is placed at the foot of the bed. At this point, we will be placing surveillance markers and the dynamic reference base. A single fiducial is placed in the left posterior superior iliac spine, which serves as a surveillance marker and alerts the surgeon should the fiducial array become disturbed. This is a critical component for assessing accuracy in real time. The dynamic reference base, or DRB, is placed in the right posterior iliac spine. The ICT, or intraoperative CT registration device, is attached to the DRB. This is a temporary fixture that needs to be seen in the medical image when the intraoperative CT is used. The patient is then carefully draped, making sure not to disturb the ICT or dynamic reference array. A cone beam CT is then obtained, and the data set is transferred to the image-guided robotic system. The drape is then carefully removed with caution so as not to disrupt the DRB.
Take it away and then come back. Okay. And now you
At this point, we plan screw trajectory by dragging and dropping phantom screws onto the robotic workstation. Planning all 8 screws in this case takes about 3 to 4 minutes. Since we are doing an open case, careful planning of the screw trajectories allows all screws to be placed within the confines of a single incision. Screw trajectory can then be checked by scrolling along the axis of the pedicle to ensure that each screw has the optimal orientation. Once this has been completed, the robot is draped and brought into the surgical field. As the robot is brought into the field, it displays that its positioning is capable of accessing all the planned screws. The robot is then stabilized to the floor. The end effector on the robotic arm is then registered, and screws are selected as the robot navigates to the pre-planned trajectories. The robot is deployed by selecting a trajectory on the screen and then depressing a foot pedal. Verification of accuracy is visualized on the screen, and real-time image guidance is used to watch the drill follow the plan. Given the extreme rigidity of the robotic arm, there is no need for K-wires or tapping. Holes are drilled and the screw is placed directly. There is feedback on the monitor given if the drill should skive. There's also constant monitoring of accuracy with warnings given should the reference frame move or the robot become inaccurate for whatever reason. After all the screws are placed, verification is performed with additional imaging to check screw placement. The decompression is then completed with facetectomies and correction of lordosis. Final correction is achieved with rod placement. The usage of robotic assistance can be invaluable in open cases with abnormal anatomy or in all minimally invasive cases where screws can be placed accurately without the need for excessive real-time fluoroscopy.
Okay, so that shows you the workflow. And so I can skip through this because the video worked. And so what was really exciting about being at Hopkins at this time was the ability to be involved in robotics with the Excelsius at the ground stage and be involved in some of our earliest publications. And I'm going to be honest that some of these first cases were really challenging. There were lots of bumps. We had the engineers from Globus in the room with us, and we were fixing lots of things as we went. And it was really important for us to study these cases as well. So we looked at our first 5 cases. You can see these ranged from 1 to 5 level thoracolumbar fusions. We looked at what our blood loss was, which we felt was pretty reasonable. And we also studied our overall radiation exposure. And we saw that you saw the workflow that we presented here, which is not the workflow that we currently do because it's a lot more streamlined to do the preoperative CT scan with the fluoroscopy, but that this is one of the options that's available. And obviously the second O-arm confirmatory spin is something that Dr. Theodore does. It's something that I personally do in my practice because I like to know intraoperatively that everything looks great and not have any questions post-operatively if a patient's complaining of any particular new symptoms, for example. But you can see here that we see radiation reduction for staff that's quite significant, as well as for patients themselves, as compared to the MIS traditional fluoroscopy for these fusion cases. And we also saw that we had very good screw placement when we did with Gertzbein-Robbins grading from a blinded neuroradiologist. And then we kept on studying and kept on looking at how we were doing. So across our first 26 cases, we saw a decrease in EBL for our robotic cases, which are shown in the RA column compared to freehand. And we also saw that our length of stay was also getting shorter for these cases as well. Then we wanted to see, because one of the really important parts of robotics is that you can have these preoperative plans, and how well are we actually doing intraoperatively? So compared to these preoperative plans. And so we looked at planned versus actual screw trajectories and found that these were actually quite good. So particularly what we looked at was mean screw tip deviation, which was a couple millimeters, mean tail deviation, and the mean angular offset for screws that we placed. And that the mean angular offset ended up being about 2 degrees. So basically how close to the plan that we're making on the screen, which you can do preoperatively when you do the preoperative CT scan. You don't have to do it in the operating room as was shown in the video. And so early on, we learned that robotic screw placement using this robot is feasible, it's safe. Our screw accuracy is high, and our planned versus actual screw trajectories are similar. And OR time is reasonable. It's definitely longer at first. The robotic cases are shown in blue, and the time is obviously longer than the freehand red line. But you can see that the learning curve, that things improve considerably over just the first 20 to 30 cases. And so beyond open fusions, robotics, the preoperative CT workflow that I didn't show you with the intraoperative fluoroscopy is far more efficient. There is a great video by one of my friend and colleagues, Dr. Laura Snyder at the BNI. So she has published a similar video. We did the open one for the Excelsius, and she's shown this wonderful video on the MIS workflow for a TLIF. And so I encourage you to see that in operative neurosurgery. And I think that the robot is really ideal for use in some of these MIS cases. So an MIS TLIF is really a perfect use, in particular the Globus Excelsius robot, because the robot does not attach to the bed. So you can easily bring it out of the way, and then you can bring in your microscope for your TLIF portion and still use the navigated pointer, for example. And I find that to be a very, very good use of robotics. Robotics can also be very helpful in complex cases. So here's an example of a higher grade spondy. And this is a case where the robot actually allowed us to place a fairly unusual trajectory screw, not a common one. So when we were doing the planning, we realized, and this happens to many of us. I was just doing an L5S1 spondy yesterday, and it wasn't anything as bad as this one, but sometimes you can see how close together some of your screws can come. And in this case, the L4 and L5 screws were actually hitting each other, and the S1 screw would have completely hit. So we ended up doing a transvertebral screw here that we planned and placed using the robot. And here is the post-operative imaging. So this is an example of using a robot to do something different and more complex that we wouldn't have necessarily even thought of. So I'm coming to an end here, just a couple more slides, but the robotic culture is also very important. So I discussed navigation, which I think is critical, and robotic technologies. They can streamline, accelerate, and improve screw placement after an initial learning curve. I do think that these really help decrease the cognitive and physical workload for the surgeon, in the sense that the screws become just a less cognitively and physically demanding part of the case. But the setup is particularly important. So both for navigation and for robotic technologies, setting up the equipment, registering it can be extensive. There's a learning curve to this. And so I think it's really important that you have a consistent team in the operating room, both from a nursing and a scrub perspective, as well as from an industry representation perspective, to make sure that this goes smoothly, because otherwise that can be a big hiccup for you. So I think that's also an important component to either navigation or robotic culture. So in conclusion, I think that navigation is becoming the gold standard for spine surgery, and robotics in conjunction with navigation is a powerful emerging tool. The current spinal robotics are really useful for navigated screw and interbody placement, and the preoperative planning platforms, I think, are excellent to be using both in open and MIS cases. There's obviously a significant increased competition in the spinal robotics space, and I think that that's helping us to accelerate some of this technology development. I'm really excited about some of the new developments coming out from the robots on the market, as well as some that we may see in the next few years, incorporating navigated drilling, decompressions, osteotomies, rod bending. So I wanted to thank the Hopkins team and acknowledge them, many students and residents and fellows involved in this work, as well as my team at Stanford. Thank you.
Hey, Corinna, it's Victor. Great talk as always. More of a philosophical question. I think that the power of the technology of robotics is fairly well demonstrated. But from a training perspective, I'm old enough where I used to do stuff with fluoro and Jamshides and K-wires. And then I picked up image guidance, and then when the robot was available, I adopted that readily, where basically I don't put a thoracolumbar pedicle screw in without the robot right now. And so when I'm training residents, that's all they see. And so if for whatever reason, I haven't had this happen, fortunately, but if you have an equipment failure or some malfunction with your image guidance, your robotics, is a bit of a dilemma, as a educator, because we're not training some of our residents with these older techniques. Maybe they get some exposure to it with some of the older faculty you have as partners. But, at least for me, I'm kind of curious what your take is on it, because, you're in a training program, you're younger than I am, and, kind of what's your perspective, would you say?
Yeah, great to see you, Victor. I think that's a great question. It's something that I've thought about, and I think we really should be thinking about within our spine organizations, because even though I'm younger than you, so when I trained, we did everything freehand, except for one surgeon, Dean Shao. He was using a little bit of navigation at the time, but I was trained to do everything freehand. We did a confirmatory O-arm spin to make sure everything looked good in the operating room. And then when I started at Stanford, which was now 4.5 years ago, there are five neurospine surgeons, and the two youngest, so one guy and we were using navigation, and now essentially everyone is using navigation. So in the last 5 years, our residents have seen where it came in where just the two young people were doing it, and now even our senior spine surgeons have started to use it. So we have some of the junior residents who really have not done freehand screws, and even one of our spine fellows last year, he was really excited because the O-arm was delayed one day, and I was like, okay, we're just going to freehand everything while we wait for them, and we'll check. And he's like, oh, this is great. I haven't done freehand screws in a long time. So it's a tough situation because we have this current generation of residents who are going to get very minimal, if any, exposure to freehand. And at the same time, I feel that, I personally have, I have to balance what I think is right for the patient and what, using the technologies that we have versus training, the next generation of residents. And so when I have these navigation technologies, I can't not use them. So or robotic technologies. So what I personally try to do is I try to ask our residents before every single screw we place, I try to say, okay, show me where the anatomy, if it's an open case. Obviously this doesn't work for the, for the MIS perk screws that I do with navigation, but I try to say, okay, show me the anatomy. Where will you put the screw? And then I say, only look up at the screen. And this doesn't work as well for robotics, but this is what I do for navigation. Only look up at the screen after you've already selected your, where you're going to put your screw and do it. And then you should only be using the navigation screen to make very tiny adjustments, like 1 millimeter adjustments, and just changing your hand a little bit. But it's not the same because obviously, they have it as a crutch. So I don't know what the right answer is. That's what I've personally done, but I do think that it is a big problem and that we should be talking about it and trying to figure it out. But at least in this sort of medical legal climate, when you have access to these technologies, I don't know how you can, not use them, for your residents just for the sake of training them, right? This might be sort of similar to what, some of the vascular surgeons have had, right? With endovascular suddenly becoming so popular, right? For so many of these, say basilar tip aneurysms, for example, right? And then the question is like, well, who's going to get trained on open clipping of basilar tip aneurysms? I know some of the guys were talking about this, I don't know if they still talk about it, but I don't know. Paul, what do you think?
I agree with you. Actually, Bill Taylor had a question for you, but
sorry.
It's becoming an issue, and there's certain markets like New York, everybody navigates, and they'll cancel a case because it's more for the medical legal ramifications. So I think you're on point with your views right now. I think it's an issue that in terms of resident training, it will become a problem in the future, but it's becoming the de facto standard in some ways.
I don't know how you, Bill Taylor from UCSD. I don't really think that the resident training is an issue at all, to tell you the truth. I mean, I'm so old, and I'm glad to hear you say that even old people can learn new things too. But I mean, when we first started, we did things open with no fluoro and flat plates, and you would never go back there. So I don't see us going back. I just see us moving forward, and I don't see the resident training being an issue at all. I think you can see the anatomy better. The only thing I really worry about, though, is, I mean, everybody shows a picture of the Da Vinci robot when they say, oh, this Da Vinci robot, it revolutionized, and spine's going to do the same thing. We try to jump on board, but the Da Vinci had real outcome differences. I mean, the patients did better. And I mean, everything that we show is perfectly great. We can do this, but are we making an outcome difference? Number one. And number two, I mean, everybody tries to say, oh, I can place pedicle screws better. But I mean, I don't know if we're really gaining any advantage over navigation. And the third thing is, my real concern is the FDA is never going to approve an autonomous robot. That's the biggest issue. And maybe I'm wrong about that, but when I was involved, it's like semi-autonomous robot and that's it. And we're never going to get past that. So I don't know what you think about those.
Hi, Bill. I've heard about you from Joe Osorio, who was one of my co-residents. So he says really great things. So nice to see you virtually. I think all your points are excellent. I know I was asked to talk about robotics, but I agree with you on the point that right now I don't believe that robotics offers more over navigation. I think that navigation is standard of care and it's definitely improved, but I have yet to see the transformational component to robotics over just standalone navigation. So that, I think that's a really good point. And then there was one person in the webinar chat who mentioned that maybe students can have rotations in countries with limited resources. I think that's actually a really interesting point because I have recently gotten very interested in some international work, and I serve on the World Federation of Neurological Surgeons Spine Committee. So a few weeks ago, I was in Kinshasa, which is the capital of the Democratic Republic of Congo. And it was my first time to sub-Saharan Africa, and it was very eye-opening in so many ways, and I hope to do a lot more work there. So we actually put together a spine conference, a teaching conference there, and we had 185 participants, African neurosurgeons from every country in Africa except for Ghana, a lot of residents as well who were there. So got the opportunity to sort of hear about what their experience is like. And so we lectured to them and talked to them about how to put in screws, and obviously not really focusing on navigation, although they asked this question. And I felt, they'd asked me, do I think navigation is a standard of care? And I said, yes, I do in the United States, fully aware that almost not a single surgeon in that room had access to that. And I think one of the issues is that, and this is something I plan to work on and hopefully continue to work on over the next few decades, because this problem is difficult to fix. But, the issue is with the limited resources in those countries is that a lot of them don't have, C-arms, they don't have imaging to actually detect the spinal cord injuries, for example. And then even if they do know there's a spinal cord injury, they don't necessarily have the implants because they don't have the money to pay for the implants to do those spine surgeries. So we could theoretically get more exposure to freehand screws there, but there's so many other things that are stopping us. So the volume of spine surgeries in those countries, and in particular spine instrumentation, is low. So I don't know if we'd be able to get, if we could send, our US trainees, sending them there, that might not necessarily be the solution, but it is interesting.
That's a great discussion. I'm sorry, I think we're a little bit behind, so we're gonna have to move forward, but I just want to just comment on one of the panelists, as Rick Chua said, I suspect in